Hi there. Hello. Just checking we're all in. Welcome. First of all, can I just apologise for the delay? We've had a few technical issues, and I'm sorry. I know it's been a busy day for some of you. So we'll make a start. Just to introduce myself, my name is Amanda Elliott. I'm the Strategic Health Lead for Contact, and today's Facebook Live is a pretty special one for us because we're looking at medicating children for mood and behaviours. And I'm absolutely delighted to be welcoming Dr. Mark Lovell, who is a real leader in this field. He has many job titles, but he's uh, a consultant child and adolescent learning disability psychiatrist with a special interest in autism. He is currently Associate Medical Director for CAMS at Durham and Tees Valley CAMS, which is part of Tees, ESC and Weir NHS Foundation Trust. So he has many fingers in many pies around psychiatry, prescribing, and many other things. So we're very, very lucky to have him here. Just a few house rules and issues. Mark is unable to give any individual treatment advice, so please be aware of that. He will be talking generally about prescribing. You may have questions that relate to your child, but if you could keep them general as well. And I probably don't need to tell you this, be incredibly mindful about sharing any of your loved one's personal details on Facebook pages, because obviously they are vulnerable and we don't want anybody regretting that. This is a live stream. However, if you can't stay for all of it or you miss any of it, we will be posting a recording on Facebook and on our YouTube page. And if you've received communications for us, we'll be sharing the link back with you afterwards. In terms of questions, the format is going to be me asking questions of Mark based on feedback and our helpline inquiries. But if you want to post your questions, we will be monitoring the chat, and if I can appropriately bring in a question at some point, I will. If we don't answer your question, we'll endeavour to follow up by, you can email us or we'll follow up with answers. So I do apologise for that in advance. Mark, welcome.
Hi.
Hi. Should we just launch into the questions?
Yeah, let's just go straight into it.
Well, Mark, the first question that I have is a sort of very general one, which is typically children who come to your clinic where you start considering psychiatric medication. I wonder what their typical presentation might be. I mean, I'm sure there's quite a range. And also, and when you're in that situation, what are the main guidelines that you will start using when you're considering prescribing for children and young people?
Okay, so often children come to my attention through three main routes. One would be either through sort of a parental referral to my team, or via school or social care, so through another agency or professionals, or through my own team knowing the child already, and then they raise sort of concerns that a child might need to be seen by myself. There are two main sorts of circumstances when it comes to medication. One is where a child has a neurodevelopmental condition like ADHD, which is going to be lifelong and will be developing over time to a point that people have concerns. So that is something that's always been there, that has reached a sort of a clinical threshold, a level that I might get involved. And often that requires the child to be able enough to be not looking essentially at the levels of a toddler, because all toddlers look like they've got ADHD. They have not great attention, they run around a lot, they're quite impulsive. And if you're developmentally delayed, of course, you might still be in that developmental phase. So they need to be sort of far enough along in their development. They also need to look different to their peers of the same level and of the same age in terms of their presentation. The other group of children are one where a change has been noted. Those changes might be what we call psychological. So the child is talking about things of concern, about how they're feeling, how they're thinking, or talking in ways that are unusual. So these might reflect sort of anxiety or mood, or even things like sort of psychosis or schizophrenia, where you might have sort of delusions or unusual ideas. But the main thing I see is changes in behavior. So the child is often behaving differently or presenting in ways that are, I guess, not psychological, they're biological. So they're bodily changes. So changes in their sleep, changes in their appetite, changes in their energy, for instance, rather than saying I'm scared or I feel low or I feel suicidal or want to hurt myself. So we have these different sort of sets of symptoms. So we have psychological symptoms, we have behavioral symptoms, and then we have things that have always been there. But often I'm looking for a change. And the other thing that brings me to my attention is that we go through an escalation route, unless it's an emergency, it's out of hours at 3 o'clock in the morning and the police have been called and I'm on call and I'm presented with a child in high levels of distress who may or may not have a mental illness. Often they will come to my team, they'll have a general assessment of their needs. There'll be lots of observations, lots of communication with professionals in the family, looking at are there alternative approaches before we get to medication or psychiatric approaches. So generally we look at the environment first, then we move on to psychological approaches, the way the child's thinking, parenting, changing things around the child, and only then do we get into a situation where we might consider looking at medication. And in terms of the second part of your question was about guidelines. So the thing about guidelines is that they are guidance. They aren't written in stone. You can opt in and out of them, and a lot of the guidelines aren't really written or adapted for those with a learning or an intellectual disability or autism, unless you're looking at the autism guidance, for instance. So there are so in England and Wales we have NICE guidance, of which there are a variety of them which would apply. So the autism guidance for assessment and the autism guidance for management and treatments. And then there's an ADHD guidance, for instance, and then a variety of other ones that relate to various mental health difficulties, sort of anxiety, depression, those sorts of things. And then there is also one specifically for this group, which is sort of some challenging behavior guidance or behavior that challenges others guidance, which relates to severe behavior disturbances, predominantly in those children who have an intellectual disability. Often these guidances say this is what we do in a child who doesn't have additional neurodevelopmental problems. If they've got additional problems, you might need to use your clinical expertise to adapt the guidance or to use the guidance as a guide and use it less strictly. So, for instance, when we're making diagnoses of mental health problems, they're not always modified to a child's language level or their sort of ability to think and consider things abstractly and communicate. So there are adult diagnostic guidances out there, for instance. So there's a thing called DCLD, which are the diagnostic criteria in learning disabilities for mental health problems. And that links to an older system which is still in use called ICD-10 from the World Health Organization. And then there's an American equivalent which links to DSM-5 called DMID-2. And these are adapted guidances for how to make diagnoses. The difficulty with the World Health Organization is it only covers adults, but we are hoping in the future to have a child version of that as well, which I'll be leading on as part of a group of professionals to create adapted diagnoses.
Great, thank you. We're getting quite a few questions, and I'm noting some of them, but I kind of wanted to move on to not the sort of the bit that isn't about guidance, but the principles you use when you have a child in front of you that's in distress or experiencing, severe mental health problems. And I know you've mentioned psychobio to me as a kind of a rule of thumb, and I just wondered if you could just talk a little bit about that and what sort of process you go through when you're considering medication, because we know for families it's a big deal, saying I think my child needs to be medicated. We all know how that feels, and the judgment of others as well. So I'd just be curious to know what your process is before. You don't just reach for the pill bottle, that I know. So yeah.
Yeah, okay, so it's actually I reach for the pill bottle quite rarely, mostly because the team I work with are fantastic. They are, if you have the right resources in place and the right support, particularly for behavior management and anxiety management, for the two main presentations we see in childhood in children with intellectual disabilities and or autism. If you can get on top of the behavior management, supporting the family, supporting the wider system like school and social care, then often you don't need medication because you've sorted out the problem at source. You've stopped the triggers that are leading to the child presenting in the way that they are, and therefore they're less likely to present. The next level up, so that's the environmental or what we call the socio bits, and that's about also about making sure that parents have enough resilience. So things like respite care during the week and home support and the child being in education. So you have an opportunity to also sort of recharge your batteries as a parent. And when those things are in place, often the children don't need to go on medication. The next level is sort of psychological approaches. And these are about thinking through the child's thought processes and thinking through, but also what can we do to help that child develop resilience to the situation that they're in, their thoughts, their feelings, their emotions, what's going on around them, and that might be using approaches like modified sort of approaches. So you might modify parenting techniques, you might modify approaches for the child to do with them understanding their own anger or their own anxiety and managing those things for themselves, because we can't manage everything for everyone. If you're able enough, then you need to have some resilience to be able to manage some of your own emotions. But sometimes we're in a situation where that can't occur. We've tried managing sort of through parenting techniques like PBS, positive behavior support, for instance, and we've thought about psychological approaches using a psychologist or approaches that are non-directive, so like art psychotherapy, and there's other examples like music therapy and other things, which use a different way of approaching a child's situation and emotions to support them through the processes like play therapy, for instance, would look at reflecting to the child the emotions that they're demonstrating or the situations in the play to help them learn to move on, because most children learn through play. We might need to guide that system to get a child through. And then those where these approaches haven't worked or who are very severe to begin with might then come to the attention of a psychiatrist. And the way that I approach is, one, I'm looking at several things when it comes to what's going on. Am I looking at a symptom or a sign that I don't have a diagnosis for? So symptom based approaches. Or am I looking at a diagnosis that I can make? And the key difference there is that when we're looking at diagnoses, there are often licenses for the medications based upon age at times, which guide me towards what medication I might want to use. So the British National Formulary for Children, for instance, will say that I can use this drug and I can use that drug, but I can't use these unless I go off license. So you start with a licensed approach first because that has the greatest evidence base behind it. Usually, it also means that it's been tested out in children, but a lot of the medications I use do not have licenses. They were originally tested in adults. They weren't tested in children, or if they were tested in children, they weren't tested in children specifically with an intellectual disability or autism or any other co-occurring condition. Because when you do research, you try and take a pure group of children to compare, and those pure groups generally don't have anything else going on. And that means a lot of our children get excluded from research unless the research is specifically done on that group of children. Um, then when I'm thinking about prescribing, I'm thinking, well, is this child's situation severe enough that they need medication? Have we tried to do things that don't use medication? Because we know that medications, when they're started, often continue and continue for years. They rarely get reduced. They often get increased. And when you hit adulthood, they might get transferred to other models of care, such as general practice, where they might not get reviewed as frequently, or there is a fear about reducing medications in the future. And this sort of fits in with some additional guidance. The additional guidance is called STOMP and STAMP. So STOMP is about stopping the over prescribing of medications that affect the brain, or psychotropic medications as we call them, in individuals with a learning disability or intellectual disability and or autism. This was because there's plenty of research out there to recognize that overprescribing was going on, often to manage behaviors without prescribing or managing the underlying cause. The second part of this was created, it's called STAMP. So STAMP is actually about starting appropriate prescribing. So not just not overprescribing, but when you recognize a child does need prescribing for, to actively act on that to make sure that the child's needs are met. In no different, if you break your leg, you expect somebody to give you some pain relief and to fix your leg, for instance. We don't expect them just to fix your leg and not give you pain relief. It's about appropriateness of going forward. And there's a balance between STOMP and STAMP to get it right. And in children, we're often really stuck on that balance line, knowing that if we start medication, it will have side effects or could have side effects. And children with intellectual disabilities and or autism are more likely to get side effects. And if they can't communicate those to us, we might be actually causing them discomfort or pain or making their situation feel worse. And we might actually make the situation worse because of that. There are also effects, and those effects might be for defined disorders or diagnoses, or they might be on symptom control.
Great. We're getting a lot of questions, and we're about to move on. And I wanted to ask you about the types, the most commonly used medications, a little bit about them, and also we have someone posting about fetal alcohol syndrome and whether some of these apply and whether stimulant or non-stimulant medications are appropriate. So thank you for that question. It's just I wondered if that was something that you saw in your clinic as well. But really, the question is about what are the most commonly used medications, and I'm quite curious to know, for example, how Risperidone, we know quite a lot of people with learning disabilities are prescribed Risperidone. I was curious to know actually how that works on the brain without getting too detailed about it. What is it that changes to make it an effective drug? Thank you.
Okay, so the broad groups of medications that we use in child psychiatry or in learning disability psychiatry are the same across the age spectrum, apart from we're generally not using the anti-dementia drugs in children. So that's the only set of drugs that we don't really get into. So if I'll start at the more severe end and work my way down, which is actually the opposite way around to what we're probably prescribing for. But so we have medications like antipsychotics. So antipsychotics were traditionally used for schizophrenia or situations that cause a psychosis. So that can occur in bipolar disorder, where you've got manic depression, as it was previously called. So at both the manic end and at the depressive end, because both ends of the mood spectrum can cause psychosis. And psychosis is generally where you have a form of detachment from reality, in that you might be hearing or experiencing other sensory things that other people don't experience, like hearing voices. You may have delusions and unusual ideas. And you can get sort of a whole set of things that disappear, like your motivation might go down, the amount that you speak might go down, your energy levels might go down, or they might go up. And we see a variety of things that happen there. So we've got the antipsychotics, and those are medications like risperidone and aripiprazole, for instance, olanzapine. There's a variety of these out there. They all work in slightly different ways. They've all been designed to be slightly different to each other. And then there's a much older set of medications out there like haloperidol, which have been around for a very, very long time. Those medications are used for psychosis, but they are also sometimes used as part of either rapid tranquilization, so calming someone down very quickly, or as part of calming somebody down. And what you're really using there, this is the Risperidone question, is you're using the side effects to form a degree of sedation. And that sedation, if you're a bit sedated, it generally makes you calmer. However, we know if you sedate somebody too far, they can actually become more leery. They can actually get worse because you're going to be more confused. You're not going to understand what's going on as much because you're a bit sedated. You might feel a bit woozy. And we know that, if you think about people going to a pub on a Saturday night, you might have someone who drinks too much alcohol who falls asleep in the corner. They're totally sedate and they're knocked out. And then you have another group who are confused, very easy to rile up, and they're getting into fights. So sometimes the side effects can work in both ways. So that's the antipsychotics. Then we have sort of mood stabilizing drugs. So these stop your mood going up and down. And there's a few of these out there. So lamotrigine's the one that's very popular at the moment, which is also used as an anti-epileptic. A lot of the mood stabilizers are very similar to the anti-epileptics. So you might see children on them for different reasons. And then there are the ones that are very similar to sodium valproate, which is used for epilepsy. And there's like variants of that, so valproic acid, monosodium valproate, and they stabilize your mood from going too high and too low. Then within the mood group, we have the antidepressants. So there are older style antidepressants, which have more side effects, and then newer style antidepressants. Say newer, they've been around for quite a while now. But those are things like fluoxetine and sertraline, particularly for this group of children. And fluoxetine, for instance, is mentioned in NICE guidance for depression. It's the most used one, has the most evidence base behind it for mood disorder or for depression. And what they do is they raise your mood. A lot of those medications also help with anxiety. Anxiety often goes alongside mood, and we know that for some situations, there are licenses for some of the antidepressants to be used for anxiety situations. And we know that they work quite well for a lot of children, but often at lower doses than you would expect to use. So we might be using things like microdosing, so using tiny, tiny little amounts. So I've had children where a regular dose for fluoxetine for depression in an adult or a child will be 20 milligrams. You might start at 10 and go up to 20, and that's where you will probably stop. I'm using doses where I'm looking at 1 or 2 milligrams and still getting effects. Sometimes using less actually produces a better effect, but it does mean that you've got to start very slowly as you're prescribing and monitor a lot to see if you're seeing differences, and then trying to fine tune the dose over time. And it will take longer to get there, but you're not over prescribing and you're prescribing appropriately. So fitting within that stamp guidance. Then we've got medications for things like tics. So tics and Tourette's, those medications generally use the antipsychotics. They help with tics, but the difficulty with tics is that they come and go. So as they get worse, you might put a dose up, and then they get better. So you leave the dose alone, and then they get worse again, and you put the dose up. So there's always a danger you're going to be adding extra. But the tics would have come and gone on their own. But for some children where it's causing harm, like they've got a severe neck tic, for instance, that is hurting their neck, then actually you might prescribe that. Or where it's causing severe levels of distress, the child's getting mercilessly bullied, and the child really wants some medication. But they all come with side effects. Then we've got medications for sleep. So predominantly that is melatonin, either in its short or long-acting version. And then for short-term sleep issues, where you're using sedation rather than using a hormone that effectively we produce normally in our brains, you might use some of the sort of sedating antihistamines that you're using the side effect of the antihistamine, and that antihistaminergic effect makes you a bit sedated. So things like Risperidone, for instance, sedates children, sedates adults as well. I have a cat allergy, and when I go to my friends' houses, when I've forgotten to bring my antihistamine, I always say, a friend always hands me over the child's Risperidone, and then I feel woozy, and it sends me to sleep. And so actually, so they are sedating. And then we've got other medications that we use in children, like ADHD medications. And they split into two major groups. We've got stimulant medications and we've got non-stimulant medications. The stimulant ones are your sort of methylphenidate and dexamphetamine and lisdexamphetamine. And then we've got, and they generally only work for 4 to 8 to 12 to 13 hours. There's a time limit on these medications. And then we've got the non-stimulant medications like guanfacine, which can also help in tics. And we have atomoxetine. Both of these work over a 24-hour period. They generally don't work as dramatically as the stimulant medication. You see an almost immediate effect. Within half an hour of stimulant medication, you can see ADHD symptoms go down. But they all come with side effects, which we have to monitor. So those are the main sets of medications that we use and see within child psychiatry.
Oh, that's great. I think probably just briefly you could explain, you mentioned it earlier about prescribing off license. I just, for clarity, or off label, just very briefly what that means. And because sometimes that's confusing for parents. Yeah, and also we've also got some questions about children with might have complex health problems or rare chromosomal disorders who it seems to be that they find it harder to get that require psychiatric medication, but there seems to be a narrower choice of what they can have, or possibly no medication at all. So maybe if you could touch on that as well, that would be great.
Okay, so this is an out-of-date copy because I generally use the online version now. But there is a book effectively called the BNF for Children, so the British National Formulary. And within this, it gives you the list of medications which are for children and across all of the health spectrum, not just for mental health. So there's a section in there for mental health, a section for ADHD. And the licensed medications are ones that when a pharmaceutical company created them originally, they sought a license for the use. So the more licenses you have, the more medication you sell. But those licenses cost multiple millions of pounds for a pharmaceutical company to create. So they're only going to get licenses for things that they want to get a commercial element from within the market. And older medications, you often stop getting new licenses because after I think it's about 25 years, patents end. And when your patent ends, anybody can make your medication. So they've got like 25 years to make their money back from their investments. And then other companies can take their product and make it themselves in another factory and sell it for less. At that point, almost all new licenses stop because no one has the energy or the money to do it. And why would you invest in getting a new license for something that everyone else is going to benefit from if you're thinking purely commercially? But evidence base is out there, and sometimes that evidence base does find itself within the guidance that says off license. However, there is evidence to say you can use it for this situation or that situation. So what happens is, so it's like driving a vehicle. So you have a license and it says you can drive a car. But when we go off license, it's the equivalent of driving an 18-wheeler massive truck or a coach or a double-decker bus, something that is totally outside of the normal realms of your average car driver. So it's wider, it's taller, it's longer, it has more risks because you've got a load of people sat behind you or a big heavy load on it, and it doesn't stop as fast. And that's why we normally have additional licenses where you do extra tests to be able to do these things. It's a bit like, I don't know, driving with a caravan. If you've got an old license, you can just pull a caravan. If you have a newer license, you can't. You have to go on a caravan driving test to prove that you can reverse it, generally. And what that means is that you need additional expertise. So that's where people like myself come in, where we have additional training, additional expertise and experience to be able to guide using medications in an unlicensed or an off-licensed way. So it's not saying it's unsafe. It's just to say you need the extra experience. And it's not just experimenting, picking a drug at random and using it. We have this thing called Boehm's rules. And Boehm's rules is where you're operating, certainly as a doctor, alongside a reasonable body of your peers. So enough of your colleagues out there are doing the same as you to say that you're not outside of normal practice. Fortunately, yeah, for those who are pioneers, it doesn't mean that you're outside of practice because you're experimenting, but then you want to do that through research, or you want to do it through additional safeguards to make sure children are kept safe. Now, oh, sorry,
So
just
did
going to go on
you,
to the bit.
okay, carry on, carry on.
Yeah, so the bit about prescribing for children who've got additional issues, so physical health problems, or where there's a very clear cause for their difficulties, like fetal alcohol syndrome, for instance, or if you've got a variety of chromosomal difficulties, which often affect more than just the brain, they often affect the development of the body as well. You know, particularly hearts and livers and kidneys, because that's where a lot of our medications affect as side effects, but they also, that's how the medications are broken down and got rid of from the body through your liver and through your kidneys. So if those organs are damaged in any way, it can cause you a major issue with the medications, particularly from a contraindication perspective or side effects. It doesn't mean that we can't prescribe, but it does mean that we have to do it very carefully, or that there are higher risks. And it's how you approach those risks, because there are times where a risk feels too high for me to want to prescribe. One, I could seriously injure, or even, heaven forbid, kill a child by giving them a medication that causes severe side effects if they've got a condition that means that we really shouldn't be using it. We often try and think about alternatives that are less severe, but a lot of our medications hit the same pathways in the body and cause similar side effects. It is really, really difficult when a child has a set of physical health issues that stop us prescribing, because then we don't have those options available to us. New medications do come along over time that have different side effect profiles, and we might use those, or we might escalate to higher levels of expertise, where somebody who has extra expertise in a particular group of children might be able to guide based upon the evidence base or based upon risks about what they may or may not be prepared to use. And sometimes you just use very small doses, or you ask paediatrics to have oversight of the child's physical health and ask them for advice as to whether they feel it's safe, and if there are tests we need to do beforehand to make it as safe as possible, or tests we need to use to monitor a child, say for instance their heart, at more regular periods than we would ordinarily do.
That's great. Yeah, thinking about many of our children may be very demand resistant or unable to swallow or have massive sensory issues. And if they require any medication, but particularly psychiatric medication, I just wondered what sort of preparation options are available for psychiatric medications or antidepressants, because I know many families think, oh, and related to that, if a child is very demand resistant but in acute distress like severe OCD or ARFID or those kind of quite tough conditions, I just wondered if what rules are around hiding medication in food. I personally, not mentioning any names, know someone that had to do that, but they were really unsure about whether what they were doing was ethical or legal, even. That was a parent. So, yeah, so related questions about adapting the medication and how you give it to young children and young people.
Okay, so your starting point with most medications is a tablet. Tablets may or may not be swallowed, they might be different sizes, they might have horrible taste on the outside of them, but some of them can be crushed. So you can take a tablet and some of them can be crushed unless they're coated with what's called an enteric coat, which is where it's protecting it from being dissolved in the stomach. It's waiting until it gets further down in your digestive system before you absorb it, because the stomach acid might neutralize the tablet and stop it working. So you've got to be careful about tablets and crushing them, but some can be crushed, and then you might want to place it in food or drink or hide it, And placing it in food or drink doesn't mean you are hiding it if the child knows it's there. If they don't know it's there, then obviously you are hiding it. After tablets, we've got things like capsules. So capsules can be cracked open, and there's usually a powder or little beads inside there, which may or may not be dissolvable or hideable in something. There's often a reason why they are in a capsule, and that's because the thing inside doesn't taste very nice. And therefore, that can cause issues from a sensory perspective or just a taste perspective or somebody noticing it. After capsules, we've got liquids. So liquid preparations are created. Sometimes there are issues with what they're dissolved in. So they might contain sugar, they might contain alcohol, or other substances that are used to dissolve the medication, because not all things dissolve in water. So they have to be dissolved in something else first. And some of those substances aren't great for the developing child's brain, but also not great for their teeth. It's not brilliant to give a child their melatonin at night after they brush their teeth if it contains sugar, for instance. So you've got to be quite aware of what we're doing with a medication when it's a liquid. Great thing about liquids is you can fine-tune the dose very, very accurately by giving an exact amount. Using very small syringes like the diabetic syringes, you can give very small amounts of things and very accurately do it rather than just spoons, which is not hugely accurate. After liquids, there are other preparations, such as patches. We don't generally have those in psychiatry, but there are patches used, for instance, that stop children drooling, for instance, stuff like that. And I know there was at one point a patch in America for methylphenidate for ADHD, but it never made it over to the UK. And I've never heard of it since. I saw it at a conference many years ago, thought that is a game changer, that is amazing. And then it disappeared off the market. And weird thing about patches is you can place them somewhere the child can't reach, so they can't peel them off, like on the back of their shoulder blades and things. So there are patches, and then there's all these different preparations. And then within those preparations, you might have short-acting versions that just act now, the next 4 hours, the next 6 hours, for instance, or long-acting versions which will last for longer. The thing about long-acting versions is often you can't crush them because they've been designed in a way that they slowly release the medication. If you crush it, it all becomes an immediate release. So those are the sorts of preparations that we use. And I often end up on liquids. They are harder to get hold of. They are more expensive. And they often disappear off the market very quickly when a company stops making it. Then you have to find another one. The problem with the liquids is a lot of them don't taste great. And the reason for that is that there's been a general push towards not putting sugar in things for medicines for children, and therefore they're often bitter or they're hiding the taste, very strong minty taste. We know a lot of children we see don't like strong tastes, or particularly don't like minty tastes, toothpaste, for instance, and that is an issue. But there are sugar-free versions of a lot of these, and there are versions that don't contain some of the things that can affect the child's brain, and sugar's often only included in the liquids. It's not included in tablets and capsules, generally speaking. So we've got all of those different types of preparations that give us some scope for options. For instance, if a child has what's called a peg feed, so they have a tube into their stomach and they don't swallow, you can crush and you can use liquids, and then they go through the peg feed into the child's stomach, for instance. So there are ways around some of these medications, and sometimes we need to go to pharmacies to get them to make us a special preparation. So they can take a tablet, they can crush it, they can dissolve it, and then add it to a liquid to be used. But they often have very short shelf lives because they've not been created in a factory. They've not been boiled and sterilized and everything else. They've been made under clean conditions in a pharmacy, but they don't last as long, and they're very expensive to make because you've got somebody literally crushing them up with a pestle and mortar, and they're very labor intensive. But those are sort of special medication requests that can be put into certain pharmacies. I can't remember what the second bit of the question was now.
It was about, are there any ethical legal issues around hiding
yes.
for children that maybe are are refusing it for whatever reason. I guess that kind of segues into mental capacity as well.
Yeah, so we've got a few bits here. So if your child is 1, you would naturally probably hide the medication or just give it to them in different ways. I've heard of people like sticking holes in dummies and medication just being sucked in, and there's all sorts of ways of doing this. As the child gets older, you are heading more towards them having either competency or capacity. So for most parents, you can hide a medication for your child technically up to the age of 16 in their best interest under parental responsibility. This is in England and Wales, and there is other legislation in other countries if you're from Scotland, for instance. After 16, you hit the Mental Capacity Act. The difficulty that happens here is that the child's capacity for their medication has to be assessed. So do they understand what the medication is? Can they retain, so remember appropriate information? Can they weigh up the pros and cons of that medication, how it might harm them, side effects, if they want to take it, not take it, and can they communicate? So that's the capacity assessment. If they don't pass that assessment, then decisions are made in their best interests by their parents, by their school, by their doctor, so the professionals and the close contacts around the child. The difficulty is, if you've been hiding a medication for 10 years, and suddenly you ask them about it at 16, and they say, what medication? Then you're in the realms of you've breached their confidence, and that you're then trying to persuade a child to take a medication that they didn't know that they were taking in the first place. So it's always worthwhile trying to be as honest with the child. You've got your medicine, I'm going to put it in your yogurt, I'm going to put it in a chocolate bar, I'm going to put it in a sandwich, I'm going to put it in your food. Because you are working with that child rather than assuming that they won't work with you. However, some children are more resistant to change. They don't want it. They didn't want the medication in the first place. And that's going to be far more difficult. You might need to hide it in their best interests. But services like school, social services, health aren't allowed to just hide things without going through a whole variety of paperwork to allow it to make sure that it's in that child's best interests. If you are in an inpatient situation, like in a psychiatric inpatient situation, you can't hide anything without it going through a whole series of sort of second opinions and additional sort of safeguards to be in place. And there are times when you might force a medication against a child's will in it, but you can only do that in an inpatient setting. And that will be things like using injectable forms of medications. They generally go into your buttocks. They are only used generally if you are in high levels of distress and are a danger to yourself or others. And they are short-term use only. They're not used in the longer term. But ultimately, in an ideal world, the child will be involved in knowing that they're having medication, and then otherwise you will have real difficulties at age 16.
Good. Okay, that's I'll relay that information to my friend as well. I think one of the other sort of issues is if you do prescribe for a child, but they find where monitoring. So obviously you've got to look out for side effects. Someone's talking about one of their children really reacting badly to Risperidone with body tremors and everything else. So if you're having to monitor them, their physical checks, their health, the side effects, and they struggle with being monitored in that way for the physical checks, what do you have to consider, and what other kind of proxies can you use for trying to assess whether that they're okay on that medication and they're safe and that it's working and effective?
So this is really tricky because many of the children I see won't let me take a blood pressure. They won't sit still enough for an ECG, so an echocardiogram, checking their heart out. They won't stand on a height measure or on a set of weighing scales, or accept having blood tests taken. Those are the main sorts of ways that I medicate, that I sort of monitor various medications, and there's quite a few of those that need monitoring. So what I do is, in a situation where a child won't do something, we try and work out if we can get to a situation where we can. So that might be graded exposure to blood pressure cuffs. The child puts it on their parent and blows it up, or they just get exposed to it, or it's placed on their arm multiple times and like daily for months, gradually increasing the pressure, letting it down, increase the pressure again, to sort of habituate, to get used to it. And sometimes we get over that line, but sometimes not. Getting blood tests is really tricky because a child knows a needle is going in their arm, and if they don't want it, you're not going to get to do it unless you restrain that child, which is distressing for the child, it's distressing for the adults, but sometimes that might be required in urgent situations where you're really concerned, and that would occur in physical health settings as well, not just mental health settings. But you might take opportunities. So if a child is going under general anaesthetic at some point for a dental operation or something else, I always say, get me those blood tests whilst they're under. If I haven't got them before, I take an opportunity to get those whenever I can. Other proxies are, does the child say that they're unwell? If their blood pressure is dropping, they're probably going to be fainting or appear dizzy. If their blood pressure is high, you often can't tell. And in children, that's probably less likely to be of a concern. High blood pressure is more of a concern once you hit adulthood because it raises your chances of cardiovascular problems in the longer term. It is really difficult to manage these things. If it's about weight and you're monitoring someone's weight, the proxy might be, is their waist size changing as opposed to their weight? But we might do things like use wheelchair weight measures. So that's where they're much bigger weighing scale and you have to walk across it or put a wheelchair on it. And you might be able to get a child to stay within that space for long enough to get their weight rather than standing on a small bathroom scales. So it is really tricky to get some of these things. And often it's a balance of risks versus benefits. If I can't get monitoring in place, I will often say, I'm going to start at the lowest dose and go up very, very slowly up the doses so that we get as much effect as we can without causing side effects. And if by going slowly, I often don't see side effects. The child habituates to them, and often a lot of side effects happen when you first start a medication. If you start very low, you often don't see the side effects. And then you can get to a higher dose more safely with the child without causing them harm. But often it is a frank discussion with the professionals and the child around them to say, and their parents to say, if we can't monitor this, do we think the benefits outweigh the difficulties that will apply all the risks? And it is a weighing up of those two things. We weigh up cost and benefit all the time. Is there a benefit to running across the road at the moment? I need to get across there quickly. There's a car coming. Am I going to get hit? Aren't I going to hit? Am I willing to take that risk? We weigh these things up all the time in our daily lives, and this is no different.
Right. There is one question I do want to definitely ask, which is, in which circumstances would you what do you not medicate for? Because it can get very confusing. And we know distress and behaviours. I just wondered if you have some rule of thumbs and that you follow around that.
Yeah, well, it's not always a not. Often it's what will I push back on a bit more firmly. So what often gets presented to me is my child has severe challenging behaviour, I want them medicated. And for me, I'm really thinking about, well, do we know the cause? If we know the cause, can we change the cause? Sometimes you can't change the cause. They get distressed because it's windy outside. It's like, well, we can't stop the wind, but we could stop them going outside, but then that's going to impact on their life. So I don't like prescribing just to sedate somebody. I have to know why and that we've tried other things. And the things about sedation, it's not a pleasant thing to have. No one likes being sedated. So I'm very aware of the child's probably not going to like this. But for these very small doses, often that can help. I don't like prescribing when clearly it's a physical health issue. I don't see it as my role as a psychiatrist to be stopping a child from presenting with behaviours or communication, because all those behaviours are a communication that they are in pain or distress. That needs to be addressed. If they're in pain, it's unethical for me just to sedate them because of their pain. So if they've got toothache, they've got earache, they've got I don't know, a bone condition that makes their joints painful, or they've got constipation, a lot of my medications can make your constipation worse for a start. So actually, the number of times we've found a physical cause for a child's distress, we've had a situation where a child was literally constipated up to here. There was no movement of their food coming out the other end. And what was coming out the end was just liquid running around the sides. That child needed to have their bowels totally cleared out, and it's unethical for me to sedate. I was being asked to sedate them. I said, well, let's check them out physically, and we found this cause. The cause was sorted out, and they didn't need the sedation. At other occasions where it's been due to rotten teeth and tooth pain, to do with ear pain, where things have been placed inside their ear, and when they were placed under anaesthetic, and they were able to remove the multiple pieces of polystyrene and plastic bag and all sorts of Lego bricks and things that found their way inside their ear or their nose, then actually the child then became far less distressed because they didn't have infection, they didn't have irritation. So for me, often I say, look, let's check them out physically first. If we don't find anything, then we can have those conversations. And I want to think about the child in their broader context. They're the main things. Usually it's about when I'm being asked to sedate a child, I want to know far more information before I'm willing to do it. And for some children where we haven't found a cause, it's absolutely the right thing to do. At low doses and very carefully. And there is an evidence base, for instance, for Risperidone, and it has a license, but only for short-acting license, so like for up to 6 weeks. So after that, you then go off license. But there is some evidence base around some of the medications that we use.
That's good. I think also early we talked about just because a child is autistic or has a learning disability, that's not a reason to a clinical reason.
Absolutely not. Yeah. So yeah, I need to have a psychiatric or a behavioural reason like ADHD to be prescribing. If there is no medication for a learning disability, there is no medication for autism, for instance. But many children with intellectual disabilities or autism have co-occurring conditions, both physical, mental health, and other neurodevelopmental conditions, which all need to be considered to decide if there is something we need to treat or manage or help out with.
I think what I was thinking about when you were talking about children that when you're being asked to sedate or medicate a child or a young person who has an intellectual disability, perhaps who are non-verbal, it made me just remind me how important the annual health checks are for young people with learning disabilities. If you're not registered, if your child is not on the GP register, when they're 14, if you get them on the register, they can be invited for an annual health check. And one would hope it would pick up issues like constipation, pain, dental issues that need to be addressed. So the physical health of young people is so important. And I personally would add that, I don't know whether you're able to do this in your position as a psychiatrist, but where a child is in a difficult or having behaviours that challenge, that all the environmental factors that might, or the lack of support that might be impinging on that, are explored beforehand. And I just wondered if you make recommendations and push back, whether people take your recommendations, like schools and others, seriously around support.
Generally speaking, they do, particularly if they know that if they don't do it, they're less likely to get a medication. So, but then when they do it, they're less likely to need medication. So it's a bit chicken and egg. But actually, my team are very skilled at this, but also we have an intensive positive behaviour support team that runs alongside me as well, as a means to stop children going out of areas, stop children leaving their home, stop children going into hospital. So we've got 2 levels of this that run alongside my role, and I input into both. And that I fully appreciate. I've seen in the thread people say, but what happens when you don't have? And that's really tricky because it comes down to your local commissioning, and that's about sort of nagging your local commissioners for specific support and treatments. It's about your parent carer forums out there, being engaged with the wider system about getting services commissioned. I'm fully aware your learning disability CAMS, for instance, does not exist everywhere in the UK. There's more and more of it over time, actually. But and certainly learning disability psychiatrists or child learning disability psychiatrists like myself are quite rare. And I used to chair an international group of us, and there's 250 of us in the world. And most of us are in the UK, to be fair. Like at least 225 of them are here, which is great. But it is a real challenge to get those services met, particularly if a service doesn't have the expertise to offer what you require. And then you might need to go down the lines of things called independent funding requests, where you make a request via your GP to the commissioning group to ask for a particular assessment or treatment to be considered and for that to be paid for by the NHS on an individual level if there isn't a local service. And that's really, really quite difficult because, why should we expect somebody to be able to deal with something that they're not trained for? It places the clinician outside of their professional boundaries and comfort zone. And not all of us are trained the same. I trained to be a child psychiatrist, but I also trained to be an adult learning disability psychiatrist. So I have extra training, and that took extra years of training to get to that point. Whereas some people don't have that training background, or their services aren't commissioned to offer something, and it's really, really hard for children and their families. And some areas have it all, and other areas have nothing. And unfortunately, that is about campaigning locally. That's about thinking about what's needed, or asking to go to another area to get a child's needs met.
That's great. I think we've had a few questions. We're going to have to wind up very shortly in about 5 minutes because there are children and young people who need your services, Mark. So I'm very acutely aware of that. But there are some questions. There is a thing called polypharmacy which pops up, which is where children are prescribed medication, maybe something like an antidepressant or ADHD medication, and then when they hit their teens, maybe the behaviours or self-harm start escalating. Is it common for children, particularly as they enter adulthood, to suddenly be on a whole range of medication? And very specifically, are there some big no-nos around certain combinations of, say, ADHD or antidepressants or antipsychotics that are an absolute no that most doctors should know not to happen? But those are kind of the two questions, really.
Okay, so in an ideal world, you would use monotherapy, so only using one drug to treat the condition. The problem is that children often have more than one condition going on. So they might end up on a multiple set of drugs for different conditions, or they might end up on multiple drugs for one condition because one hasn't been enough. And sometimes you're balancing between effects and side effects, so you might not be able to go high enough with one, but adding a second one in which has a different side effect profile might support more treatment for that condition, but you're using two drugs at a lower dose. The difficulty is you need to have the expertise in doing this. You need to know what you're doing, why you're doing it, and you have to be aware that, in this book of words, it says which drugs shouldn't be used together, that some of them interact, some of them cause problems. Sometimes it depends on the order that you put a drug in. So, for instance, risperidone and fluoxetine, if you're using an antipsychotic and you're using an antidepressant or something for anxiety, they work as a combination reasonably well together. Sertraline, so the antidepressant, and aripiprazole may work together as an antipsychotic, but the opposite combinations cause differences in how much of the antipsychotic is in your blood. So you might accidentally increase an antipsychotic level if the antipsychotic was in place first and then you added in the antidepressants. However, if you start the other way round, if you start with the antidepressant, you might actually get away with using less antipsychotic. So you have to know how the medications work and how they interact with each other. You might have concerns with someone who has psychosis where you're giving them stimulant medications for ADHD, because those stimulants can cause psychosis in their own right or make it worse. The biggest issue is if somebody is using illicit drugs in the background alongside stimulant medications, because then you get a double effect and they might be working against each other. And then you might say, actually, no, if you're using illicit drugs, I'm not going to prescribe you another drug that happens to have a street value because it is a controlled drug. So the stimulant drugs are controlled drugs alongside other medications like cocaine or like heroin or diamorphine. So essentially, if you're prescribing something, you've got to be very careful if there's illicit drugs in the mix as well, or the danger that they might be sold on as another, unless you provide them a prescription and then they're just selling it as a drug dealer. So you have to be quite careful about those sorts of things. There are some medications that interact that shouldn't be used together, and that comes down to the doctor checking those things out as you adding and adding and adding. And they can certainly interact. What we often find is that children end up on 5 or 6 medications, or adults, all of which that sedate you, or that affects the same series of side effects. So they just accumulate and get worse and worse and worse because they're often affecting the same things. Some medications work very well together and actually lower side effects or improve things. But those are often the medications that are used in adulthood, not in childhood. So yeah, the key thing is, say, if you're a parent, does this drug, how does it work? Does this medication have side effects? Does it interact with anything else that my child is on? And if you keep doing that with the different people prescribing, like the GP, the paediatrician, and your psychiatrist, you can keep them all in the loop. Otherwise, one might add something without thinking about the medications that someone else is prescribing.
Actually, that was going to be my last question, but we're going to have to wind up. But were there sort of 3 pieces of advice that you could offer to families who are perhaps facing this situation for the first time? I think that's great advice about asking those 3 questions. Is there anything else that I mean, there was someone who posted earlier about having quite a young child that self-harmed quite severely, and that although they were on medications, it wasn't making any difference. So, if you're in that situation, should they go back to the doctor or the paediatrician or the psychiatrist and say, what's the best way to communicate with doctors about, because often the parents are the ones who know their children because they're the parent, or often if they're non-verbal. So I just wondered if there was just a tip that would help ease this process and make it more collaborative and helpful and less stressful.
Yeah, I think getting the information and pointing out the impacts of what's going on, getting professional support for any referral that's there. So it's quite difficult if something's only happening at home and never happens at school. Because it's like, well, what's different about home? Or it only happens at school and doesn't happen at home. So then you're thinking about, is there something environmental going on here, rather than it being just about having a disorder that needs medication? Because you've got to remember they're going to be sedated or treated at the time of day when they didn't need it as well. So that's the other thing. The key thing is about the information that's provided, it being credible, being backed up by other professionals when you're seeking referrals. Some services accept self-referrals. My service, you can self-refer. A child can self-refer. You don't have to come via your GP or through another professional, but other services do have that sort of safety net in place where you've got to go via GP or a paediatrician to get into a service. And the key thing is taking your information, presenting it to them in a way that they can send it on is always helpful. So if it's on a few post-it notes, it's not very helpful. It's probably slightly better to say, can I email you this? Or can I bring you electronically? Because then they can forward the information directly. And if you've got additional information like education, health and care plan stuff, or SEN plans from school, or where other work has occurred, say you've been to occupational therapy for a sensory assessment, all those reports are really helpful if they're provided up front, because then they can be considered when a referral is being managed or thought through about somebody's severity, somebody's priority, or whether they meet criteria for service. The biggest difficulty, I suspect, is a lot of children don't have diagnoses. So they don't have a diagnosis of a learning disability, for instance, or an intellectual disability. And the reason for that is that there are very few commissioned services out there to make the diagnoses. So what you need to do is bring evidence that makes it clear that that child probably does have one. And I'll do a little plug for something that I've written that's out there on the internet that's freely available. So if people go to the ACAM website, so the Association for Child and Adolescent Mental Health, I have some resources on there in the topic guides under intellectual disability about what is an intellectual disability and what information you might provide to help somebody work it out in the absence of an actual diagnosis. So there's a topic guide in there, it's freely accessible. There's like an easier read version, there's a longer read version, and a video about it as well. If that helps people get children over the line, to take them to their GP to say, if they've got a diagnosis, they would have been eligible for annual health checks, which not only keep you well now, they actually make you live longer. If you take that information, that might help the system put a child on one of those sort of watch lists on the registers.
Is there any value? I mean, this is something I did with my own son when he was having a terrible time with his mental health and he's autistic. Was I actually wrote a sort of diary over a period of time with just jotting down difficult things, because you forget when you're a parent, you're stressing. And I just wonder, I used that in several circumstances, including a tribunal, and I just wondered if there is some value in diary.
Absolutely. Because the first thing my team would ask you to do
as well, around if they're on drugs, keeping an eye on their appetite and stuff.
My team, that's the thing that we'd ask you to do anyway. So if you bring information beforehand, we've got more information available to us. It'll come down to what you can do, diary keeping, because it's hard to keep diaries and keep all records. And it will certainly help you remember, because when they say, how many times in the last 6 months has this occurred, you'll have the evidence. Whereas, wow, it's happened quite a lot. What does quite a lot mean? For some people, quite a lot is it's happened every 3 hours. For the other person, quite a lot is it's happened twice in 6 months. And they don't mean the same thing. And how severe was it? How often was it? And the key thing for any behaviour stuff is what are called the ABCs. So the A, antecedents, what was happening before the incident occurred. The B is what was the behaviour that you saw, what did occur during the incident. And then the C is consequences. So what happened afterwards? How long did it last for? What made it better? What helps? So those ABC charts are really good. They're gold when it comes to assessing a child's behaviour, because that's the sort of stuff we will ask you to do anyway. How often is it happening? How long did it go on for? And those ABC elements will help us understand the meaning behind a behaviour, because that then guides us towards what sorts of therapeutic input we might give, whether that's behavioural advice, whether it's going to see your OT, whether it's going to see speech and language therapists, or psychology, or psychiatry, or learning disability nursing, or if you're younger, that would be sort of portage and health visitors, or your paediatrician. And this happens every time after they've eaten a spicy meal. Oh, don't give them a spicy meal then. Give them something a bit more bland. And is that because the spice has irritated their stomach and given them reflux? Or is it that they don't like spicy taste and it's burnt their mouth? And then you're going to get a flare-up? Or is it that the spice is making their stomach cramp 2 hours later because they've got an intolerance to chili, for instance, and therefore you're looking for a pattern, and those patterns will guide us towards what help and advice we might offer.
I think that's a great place to finish. There's been loads of questions, and I really do apologise that we haven't been able to give specific answers. You can always follow up with me at amanda.elliott@contact.org.uk if you are looking for further advice. Mark can't give individual treatment advice. He can only give broad advice, and equally, but it may be that you have other inquiries that are not medicine related as well, and I can pass you on to our helpline, which is brilliant. Mark, thank you so much for your insight and your expertise and knowledge. It's such a massive subject, so perhaps we were a little bit over ambitious.
It's years and years of training.
But we're very glad you're in the system, and I'm sure parents are very lucky to have access to you. But it might be that we want to do a follow-up focusing in on some things that have come up that we haven't addressed. So once again, apologies for the initial difficulties and the late start. Thank you, Mark, and thank you to all the parents that posted some amazing, insightful and very upsetting stuff as well. We
they might guide a follow-up.
Pardon?
They might be able to guide a follow-up.
Yeah, absolutely. So nothing is wasted. This will be posted on Facebook to rewatch or to share with friends. And it will be going on YouTube, our YouTube channel soon as well. So if you've missed bits or you think other people will benefit or just want to recap, it's going to be there listen. So you will hear from us afterwards as well, because we'll be looking for feedback. Thank you again, and take care, everyone.
Thank you.